Thank you to everybody for attending today. We're absolutely delighted at POTS UK to welcome Dr. Boon and Dr. Melanie Dani from Imperial College Healthcare NHS Trust, and specifically from the Imperial Syncope Unit. As I'm sure you will all know, Dr. Lim is a consultant cardiologist and electrophysiologist. And Dr. Dani is a consultant geriatrician. I'm sure they'll both give you a bit of background potentially about them as well. I'm also thrilled to be joined by Professor Leslie Cavey, the chair of POTS UK. Leslie's going to take on the role of question master today, and at the end of the session she'll be looking through the Q&A box and picking out some questions for us to cover. As you'll know, the topic is long COVID and the autonomic nervous system. So I'm sure that there's going to be lots and lots of questions, extremely topical at the moment, and hopefully it will be of great benefit to lots of you. If you can add your questions to the Q&A box, that would be fantastic. If there's anything technical or anything like that that you're concerned about, or if you need anything, then pop it into the chat box and I will be monitoring that. As always, the session will be recorded and added to our YouTube channel within about 48 hours after the session. Since the start of COVID, we've done 14 webinars and they're all on our YouTube channel. So do take some time and go back and have a look. There's a real range of topics and everything. So I'm sure there'll be something there that everybody would find really helpful. At the end, there'll be a survey. It quite literally is 2 minutes. It's not one of those really detailed ones. If you are able to complete that, it would be wonderful. You'll just get the link to it at the end when you kind of click out. And that would be fantastic if you can do that, because it just helps us shape our future webinars. And then I'll just take 1 minute now, a bit of a cheeky plug of our campaign for POTS. So we're launching a campaign throughout July called Take a Stand for POTS. We are a really small team, but we have a huge amount of people supporting us and a huge amount of members and followers, and all what we're asking, and hopefully if you are members or on any of our social media platforms, you'll have kind of started to see about the campaign and about Take a Stand. And we're just asking for everybody to get involved, talk about POTS to everybody that you can, raise awareness in, you know, whatever way you feel comfortable, but just we would really appreciate your support. You know, we are a tiny team, we're a strong team, but we would just love it if everyone could get involved and change your social media images, you know, see who you can get involved in retweeting and tweeting different things, and yeah, anything you can do would be massively appreciated, because we're so passionate about raising awareness and improving services. So hopefully we'll have your support and see everybody getting involved. So without further ado, I will hand over now to Dr. Dani. Thank you so much, both of you, for giving up your time today. It was really appreciated by the charity. We know everybody's busy and we're really looking forward to the webinar. So thank you very much.
Not at all, Joe, and thank you very much, Joe and Leslie and everyone at POTS UK for inviting us to talk. And we're very pleased to be here to talk about our experiences over the last year and a bit of long COVID and the autonomic nervous system. Some people may ask, I'm sure this audience is actually very educated and read up a lot on this, but some people may ask, what has long COVID got to do with POTS UK, and what has long COVID got to do with the autonomic nervous system? And we're going to talk through what we've discovered about it over the last year and a bit, and then we're going to talk about our strategies for managing this. And there are a lot of parallels with POTS, both POTS following COVID and POTS, the condition itself, and so we will go into that in a bit more detail. So thank you. So just the next slide. So I'm sure everybody has heard of long COVID. It's pretty much all we've heard of in for the last year. It was about this time last year, so after the first surge of infections in March and April, that people started to report ongoing symptoms that weren't really consistent with the initial infection, but were going on for a month, and then even longer than that, for 3 months, for 6 months, some people going on for a year. And it was really a condition that was led by patients. So it was support groups, like, for example, you can see that Facebook group on the top right, 40,000 members. So the voice and the kind of driving agenda was coming from patient groups in the first instance. And it was much later that the medical professionals started to kind of sit up and say, what's going on here? Is this a post-viral condition? What is long haul COVID? And it really, I just want to say that this is a testament to the power of the advocacy group, the patient groups, and actually saying, this is what's bothering us, you need to listen. And so there was a headline, Boon, if you just click in, I think it was November last year, from one of the big medical journals, the Journal of the American Medical Association, that was kind of saying, you know, long haulers are stumping the experts. This is one of the first times in medicine and most of our professional careers that we've seen a disease for the first time. So seeing it evolve and actually being educated by our patients, which can be interesting. And a lot of a common theme coming is that patients or sufferers are not being recognised by their GPs and employers. So often they'll explain their symptoms to their doctors, and their doctors will do the lung tests and the oxygen tests and even the heart tests, and everything will come back normal and reassure them that everything's normal, but they're still suffering at home with these debilitating symptoms. And it was really the patient voice that was saying, you know, yes, my tests may be normal, the ones that you've done, but I'm still ill, and what's going on? And this was a patient coined term. So where does the autonomic nervous system come into it? Well, we work in a syncope unit. So syncope, blackout, fainting, and that's maybe where our association with POTS comes from. But we started to see around this time last summer, it was Boon, Dr. Lim actually commented that a couple of his referrals that were coming through very early had symptoms of autonomic nervous system dysfunction. We started to wonder, is there a link between the two, patients with long COVID and autonomic nervous system problems? So just to summarize very basically, what is the autonomic nervous system? Well, looking at our bodies, we have our brain and our spinal cord and our peripheral nerves. So the brain tells the body what to do very simply. It tells the muscles, the skin, the heart, the lungs, the brain and the spinal cord are in control. And as part of these nervous systems, we've got the somatic nervous system. So that is the brain telling the muscles what to do. So if I say now I'm going to pick up my phone or I'm going to speak to this webinar, that's my somatic nervous system working. And that is conscious control and sensation in the body. The other part of your nervous system is the autonomic nervous system. So it's just a different set of nerves and nerve endings and supplies, which controls everything in your body that's unconscious. So the unconscious processes in the body. So the first one to think about, the most obvious ones are your heart rate, your blood pressure, temperature regulation, but even more subtle unconscious processes like your feelings. So I'm feeling a little stressed now, sitting here talking on a webinar. So that's my autonomic nervous system that's kind of priming me and getting my adrenaline ready to talk. And the autonomic nervous system has two parts, just sort of conceptually thinking. It's got the part that controls your fight or flight response. So it's called the sympathetic nervous system. That's one set of nerves and chemicals. So that and again, this is unconscious processes. If I see a lion that's chasing me down the road, I start to feel terror and I run. That's the sympathetic nervous system, so the fight or flight response. And then in opposite to that, you have the parasympathetic nervous system, which is the opposite, the rest and digest. So once you've chased your lion, you then want to lie down, relax and eat some of it. And it's your parasympathetic nervous system. And normally in health, these two, the sympathetic and the parasympathetic nervous system, they work together in good harmony. So when a threat comes up, your sympathetic nervous system alerts you. It alerts your somatic nervous system to run away or take action. And then your parasympathetic nervous system calms you down, sorts out your unconscious processes like your blood pressure, your bladder, your bowel, and lets you then feel calm and sleep. And the term, just to use, because it's a term that we come across, is the vagus nerve. And that's just one of the main nerves. It's actually the longest nerve in the body. And that's the main kind of executor, so the main workhorse of the parasympathetic nervous system. And it starts right up at the top of your brainstem. And it's the longest nerve in the body. They used to call it the wandering nerve because it goes all the way down to your lower bowel. And it supplies all of the different organs in your body, so your spleen, your heart, your lungs. It's the vagus nerve that's responsible for the rest and digest. Now, we've all got the sympathetic nervous system and the parasympathetic nervous system working in constant harmony. And problems may arise when there is an imbalance between them. And that imbalance tends to be an excess of sympathetic nervous system and a decrease of parasympathetic nervous system. And just thinking the function, so this vagus nerve as it supplies the organs in the body, and these subconscious processes that the autonomic nervous system is doing is those we were talking about. So things like blood pressure, heart rate, pupil responses, emotion regulation. It's kind of subconscious if I'm feeling happy or sad. It's not something that you can, we'll talk about this later, but immediately bring control to. Temperatures and regulation, sweating and bowel dysfunction. So that's the autonomic nervous system, and that's it working in health. But what we have started to notice is that problems of impaired autonomic nervous system have started to become a feature in long COVID. So Boon, why might this working perfectly aligned sympathetic parasympathetic nervous system, why might it go wrong or become misaligned?
Well, yeah, thanks very much for the question and for taking the presentation so far. I'm just switching screens to my iPad. And let's see whether or not this will pick up. I hope it does. But the autonomic nervous system in relation to cardiovascular physiology, and this is what I want to really start to point out, hopefully with an illustration that will come soon. Yes, I am sharing screen. I think can be shown very clearly from an illustration that I'd like to share with you. So this is an animation from a website that we created at Imperial. It's called stopfainting.com. It's a freely available resource. But what I would say in relation to the autonomic cardiovascular regulation, and in particular in relation to postural orthostatic tachycardia, is that when somebody stands up, i.e. changes posture, you can see this red stuff circulating around, which is plasma and blood, starts to fall. So I'm just clicking on the bottom red bar here, and you can see that as you stand up for a few minutes, the blood is literally being taken from your heart and your brain, which are the central or core circulatory components that maintain kind of a healthy blood pressure and feeling of wellness in your brain, because you need perfusion to the brain to be mentally alert and sharp. And so what happens in a standing position in a patient who is susceptible to orthostatic challenges is that the blood volume can track down, and literally this falls with gravity. And so the lower limbs start to fill with blood. The heart, as a consequence, empties of blood, and therefore the blood pressure is starting to reduce. Now, there are two very sensitive receptors called the baroreflex receptors, or the carotid baroreflex, which send a signal to the brain to say, hang on a minute, my blood pressure is falling, and therefore let's execute the anti-blood pressure falling mechanism. And this is also known as the fight or flight response, also the sympathetic or stress response. And this is what we've come to recognize very clearly on our tilt table testing, that patients who develop this reaction to pooling of blood from the heart and the brain into the lower limbs, but also into the splanchnic bed, which is where, for example, after you eat a large meal, you fill your gut with blood that I've drawn there. You generate this fight or flight response, and the adrenaline system or the stress response has to try and increase your cardiac output, which is the amount of blood circulating in 1 minute. And it does this by increasing your heart rate, because ultimately the blood pressure is something like the stroke volume. The stroke volume is every pump of your heartbeat, how much blood comes out. If you multiply that by the heart rate, you get a cardiac output in a minute. And so you excrete or secrete a lot of adrenaline or a stress-like response to increase the heart rate, to increase the contractility of the heart, so to increase the strength of the heart's contraction, which may explain some of the chest pain that some of you may face. It also increases what's called vasoconstriction. And vasoconstriction is this ability for the sister hormone of adrenaline called noradrenaline to squeeze the vessels, to then hopefully push the blood back upwards into the into the heart and the brain and to improve that blood flow and blood pressure. But adrenaline also has several other effects, for example, causing problems with your gut, including symptoms of IBS or bowel peristalsis that is very vigorous, and so people can get diarrhea alternating with constipation. And adrenaline can also have an impact on your brain because it can make one very hypervigilant, very reactive, and also cause other problems such as insomnia. So if I come back to the main presentation screen now, and if I pick that up where Mel left off, we can see that the whole process that I've drawn for you earlier on is part of what happens when we have this blood pressure falling, and a reaction to that blood pressure fall being the triggering of the sympathetic nervous system response. So that explains why it's postural in nature. It defines, or it's part of the definition of POTS. The first two words, postural and orthostasis, means changing posture. And the reason you get tachycardia is because of the mechanisms that I've described. And therefore, if we take what I've said to the next level, what are the potential effects of having such a high level of adrenaline switched on all the time when you're standing up or even seated? It can impact your body in the various ways that a heightened fight or flight or stress response would do, such as seen here. So dizziness on standing, fainting, palpitations, fatigue, brain fog, insomnia, anxiety, depression, difficulty in emptying bladder, holding on to the urine, excessive or lack of sweating, and bowel pain. These are all the things that some of the patients with POTS may suffer with, but also we've seen start to develop in a cohort of patients with long COVID and autonomic dysfunction. So Mel, back to you.
And so bearing that in mind, thinking of what are these symptoms of autonomic dysfunction, this was one of the very first papers that came out at the end of last year, and it was a preprint, so it wasn't at this point sent for peer review, but it was a survey of every single possible symptom. It probably doesn't project very well onto your screens, but this is just to highlight the extent of symptoms that people experience after COVID. Now we know that the symptoms are wide, we know that they're common. So the latest report from the REACT study just last week was that there are 2 million people in the UK who are reporting at least one symptom going on after COVID. But if you look at the extent of this, there are things like very sort of wide ranging, so problems in the ear canal, bloodshot eyes, or they go down to the more frequent things that we hear about of the fatigue and the post-exertional malaise. But again, the one theme which we've highlighted in the red circle are these features of autonomic dysfunction. So palpitations, tachycardia, bradycardia, slow heart rates, fainting. And looking through the spectrum of symptoms, a lot of them can be tracked back to the diagram that Dr. Lim has just shown. So problems with fatigue being one of the commonest symptoms, the brain fog, the overwhelming difficulty in exercising, along with bowel issues. So it's a sort of multi-system disorder that's affecting the whole body. So this again is starting to come through, that a lot of the features, the wider features that may not be recognized as part of autonomic dysfunction are a common feature, but also a common feature of long COVID. So this all came out around last year, and we started to again see patients coming through clinic, and this is just a list of some of the patients that we saw in the early part of last year. And again, it's not to go into it in an awful lot of detail, but just to look at the fourth column from the left, just showing that a lot of these patients were having normal tests. So they were being referred up to the hospital or to the specialist centre, having been to the long COVID or the post-COVID clinic, been to their GPs, been to other specialists with normal tests, but were still very symptomatic. And one of the reasons for that is that actually some of the symptoms of autonomic dysfunction may not be picked up, because these are quite specific to standing up and may not be detectable if the right tests aren't done. The other thing to notice is that the majority of the patients that we saw have been sort of middle-aged females of working age. anything between 20 and 60. That does tend to be replicated in bigger cohorts and studies, and nobody really knows why. There's probably a gender-related difference in the immune system. We know that men are more likely to die from COVID. We also know that women are more likely to pick up autoimmune conditions, so there might be something related. But this is just to highlight that we've seen a lot of patients, and when we performed some of the autonomic tests, so the cardiovascular autonomic tests, like a tilt table test, we've seen features. And I suppose one of the things that Boon's just going to talk through some of these in a bit of detail, just to show what could be happening in a patient with typical autonomic dysfunction after COVID. And I guess it's just a bit early at the moment, something to say that we don't quite know what really this means. We think there's probably a spectrum. So some patients will have very bad symptoms, but maybe a normal tilt. Other patients might have quite mild symptoms, but an abnormal test, and it's just working out and gathering information at the moment to understand the significance. But this was a lady that we saw quite early on. So she had COVID in the first wave in March last year, presented with 4 months, after 4 months, with just persistent fatigue, which was draining her, but dizziness and lightheadedness when she was standing. And this was worse when she'd been standing for a while or when she was premenstrual. And this is her tilt table test that Boon will talk through now.
So the tilt shows, for those of you who've not seen a tilt, this is one of the tilts that we typically get from the PhenoPress continuous beat-to-beat blood pressure non-invasive cuff that we put on your finger. And when you attend for the tilt, these are the kind of printouts that we might get. So on the x-axis is time in 2-minute bars. Each of these bars is 2 minutes. And on the y-axis here is heart rate in this lower trace and blood pressure, with the systolic in the upper trend line here and the diastolic in the lower trend line here. So what you can see is after 5 minutes of lying supine, which means lying flat on the bed is tilted 60 degrees up. So you're promoting that pooling response of blood going down in your lower limbs. And what you can see with this patient with long COVID symptoms is that there is an immediate increase in heart rate from approximately 65 to 100 and let's say 103 beats per minute. And thereafter, the heart rate appears to oscillate. I don't know if you can pick up these oscillations, which is a very, very clear characteristic, in my opinion, of patients who also display non-COVID POTS-like physiology. And this may explain some of the varied symptoms that one might get, which I'll come on to in a short while. But the other thing I want you to notice here, please, is that there are these artifacts, and these are calibration artifacts that you should ignore. Beyond the artifacts, these blood pressure traces are real. And therefore, what I like to say that is that even in the supine position, your blood pressure is never static. So when you take your blood pressure repeatedly and you get a reading of 115/80, and then the next reading a minute later is 120/82, it doesn't mean the blood pressure machine is broken. It's just your normal fluctuation of blood pressures over a 10 to 15-second cycle. And boy, does this exaggerate a lot. Look, the difference between here, before the line, and after the line is incredible, because what you can see this patient does is that she oscillates greatly. So here the systolic, for example, runs from 125 down to 95. And that means on a kind of 10-second cycle, there could be a 30 millimeters of mercury drop of systolic blood pressure. And you can see this oscillations continue to occur throughout the whole of this tilt, mirrored by oscillations in the heart rate, as you can see here. And what that tells you is that there is some degree of resonating frequency within the sympathetic nervous system that is, on the one hand, getting highly expressed, causing that tachycardia, that vasoconstriction, that impact that it wants to give to increase the blood pressure. And then on the other hand, the release of adrenaline. For example, when your blood pressure is already high, the adrenaline is switched off, and then you get this down surge to a nadir of blood pressure reaching 80 here. And then you activate the sympathetic nervous system again 10 seconds later, and then you reach a peak of say 115 here, and so on and so forth. It goes like a yo-yo. Imagine this occurring in all bodily systems, because this is primarily driven by a surge and release of the stress or the fight or flight response. And how this patient feels in this just simple test of tilting, which is equivalent to standing upright, manifesting all these hemodynamic changes underscored by the increase in sympathetic nervous system activation, is potentially a very clear physiological explanation for all the symptoms one might see. These are a panel or a selection of different traces from 6 different patients in a cohort of patients. And you can see that they all display very similar physiology with oscillations. You can see oscillations here, oscillations. There's one exception, which is this patient, who developed quite significant vasovagal syncope. And I think the diagnosis here was slightly different from the rest. But just to give you a spectrum of tilt traces to look at and appreciate. And this was a particular patient that I won't spend that much time on, only to highlight to all of you that sometimes when you try fluid, salt, compression stockings, and everything else, especially in the long COVID context, and you're still failing to improve, as this patient failed to improve significantly with this particular trace, which in my mind shows very fine but not that significant oscillations here, with a heart rate profile that again wasn't very oscillating. The drug that for this particular patient, on an anecdotal basis, but now building up numbers, the drug that really made the difference to quell the fire in her brain, in her own words, was taking an antihistamine. And she took fexofenadine, 180 milligrams BD. And this really resolved a lot of her symptoms. So there's some things we still don't understand. And this may be to do with an overlap with something that I will not spend that much time on, which is something called mast cell activation disorder, which we're starting to, in my experience, see some corroborative evidence from the impact of antihistamines on helping patients improve. So I'm not suggesting antihistamines for everyone, but this is experience from my own learning to see that what has worked and hasn't worked in patients. But I'll come back to management with Mel, because there's some basic things that we ought to be doing for symptoms.
And this comes back to the principles of a lot of different features of autonomic dysfunction, so POTS and vasovagal syncope, and a lot of the syncope patients that we see in our clinic. And one of the rationales for this is in some of one of the possible causes is a lower plasma volume, and that's often, it can be after an acute illness like acute COVID, but also if you've been supine for a period of time, or you've become deconditioned or become very unwell, your actual blood volume can become less, and so then that exaggerated response that Boon was talking about can become more marked. So one of the treatments is increasing your plasma volume by drinking fluids. So we recommend 2 to 3 liters a day. And if you have a low blood pressure, so if you've been told that your blood pressure is low to normal, adding salt to your diet. Second thing, compression garments. So you may well have heard of these around your abdomen or your waist or your thighs in particular, to squeeze the blood vessels, in the big kind of blood vessels in your abdomen and pelvis, and improve blood returning to your heart. And the physical counter pressure maneuvers. So modeled by one of our colleagues, squeezing the big muscle groups of your thighs, your buttocks and your abdomen can help improve blood back to the heart. Also educating yourself, so knowing the underlying causes, attending webinars like this. Most of the time, these quite simple principles are enough to actually help. Very occasionally, if they're not, and we're going to talk through some other principles that we also strongly believe can actually help realign the autonomic nervous system. But occasionally, drugs may be recommended, and they may be to improve your blood volume or to help squeeze those blood vessels if the compression garments aren't doing it enough. Sometimes, if you have a picture, so on your tilt, or if you're on your symptoms, you have a very fast heart rate and high blood pressure, and you need something to dampen down those features of adrenaline and noradrenaline, then a medication to dampen that down, like a beta blocker, may be helpful. In long COVID, there haven't actually been any studies to date on medications, but the advice that we give is based on our knowledge of autonomic dysfunction in other conditions. Returning to exercise is one of the questions that we're very often asked about, and could be a topic for an entirely different webinar, so I'll go very quickly through it. But the principles really are a graded program, so starting very low, and often patients may come and say, listen, I used to be very fit, I was running half marathons, and look at me now. And just whatever you do is to avoid the temptation to go back to exercising too soon. So the basic principles would be to wait until you're completely asymptomatic from any sort of viral infection for at least 7 days, and then to work in gradual phases. And these phases should be at least a week, but could be longer. And starting at negligible to very light exercise levels. And when we talk about negligible, we would start by lying on a mat and breathing, and maybe stretching the core and the lower leg muscles, and then gradually incrementing. One of the features of autonomic dysfunction and orthostatic intolerance, so difficulty standing, is that you will get worse on exercise if you stand up. So we recommend starting with recumbent exercise bikes, which I'm sure you've heard on other webinars, but recumbent exercise like swimming or an exercise bike, and very slowly incrementing up, and never going further if you're feeling exhausted or symptomatic from the day before. And that's just really the principle. But actually knowing how long that will take is different from every patient. And the real thing to emphasize is patience, which is and just not pushing yourself. And so that's just a suggested possible kind of solution, but everybody is going to be different. So we can move on to the next slide. But one of the things that we wanted to talk about is the top-down and bottom-up approach. So Boon, what does this mean? What's top-down and bottom-up, and how does it apply to the autonomic nervous system?
So this is the title of this talk, and really we wanted to spend the next 15 minutes really focusing on this. And so I'm a consultant cardiologist and electrophysiologist based at Hammersmith, and in all the years I've been practicing in this, I would say, very evidence-based and scientific approach with drugs, with trying to understand physiology in the way that medics know how to understand physiology, which is always with data and science. I've neglected what I should have not neglected for many years. And my brother is a yoga instructor, and he said to me many years ago, do some yoga. And I always said I never had time. I still don't have time. But in recently adopting a very, I wouldn't say yoga, but a very breath-based existence, as in an existence focused on breathing, including a breathing exercise that I did before I started this webinar, it has led to a wonderful change in my own personal day-to-day relationships, in my career, in my ability to handle stress. And so for me, this experiential learning has been wonderful. I don't know the yoga literature very well, but I'm asked now more and more to review the impact of yoga therapy on all sorts of conditions, including atrial fibrillation and vasovagal syncope, because that's my skill set. And really the data scientifically is starting to support this. And so why not put it in practice? A top-down approach is one in which I consider an approach to influence your autonomic nervous system by a feeling or an emotion. I'm showing you my finger, if for those of you can see me on the screen, and I can move my finger by saying finger move. This is a conscious thought, and it activates the somatic nervous system, which is the conscious brain, to move the finger or to deliver this webinar or to form words or phrases. Now, I'm going to ask all of you now to try to increase your heart rate. Can you do it? Is it simple? Can I just say, okay, now heart rate slow down. Can you do that? And the answer is, you might think that's a crazy thing for me to have said. How the heck am I going to decrease my heart rate? But actually, if I said, now think of a moment where you were very angry or very frustrated with your boss, your colleagues, your somebody who was behaving in a, somebody who cut you off on the street or whilst you were driving, and live that anger again. You could increase your heart rate, and it's conceivable that you can do that. What is the opposite of that emotion, that anger, that frustration? The opposite of that is an emotion which is positive, and therefore, if a negative emotion can increase your heart rate, guess what a positive emotion can do? It can decrease the heart rate. And as we know from the beginning series of diagrams of the autonomic nervous system that we showed, the link between the autonomic nervous system and the heart is through the vagus and also the sympathetic nervous system. And so you're able to directly control the autonomic nervous system from a thought. So that is a top-down approach. And it's something that I think we neglect a lot when we speak to patients. I personally, in the historical past, never used to cover this, but I think it's becoming more and more a day-to-day important practice, especially in long COVID, because it's not good enough to say how you're feeling when you stand up or what your symptoms are from a palpitations or from an IBS point of view. It's actually important to say, do you fear your career is going to be in jeopardy? What are your relationships like? Do you have a means to pay your mortgage payments? Can you ever get back to full health? What is your thought about your health recovery? And these patients have so much of the top-down approach, continuing to drive a sympathetic process that actually it becomes all-encompassing. And so more focus needs to be given on this. If we now talk about a bottom-up approach, this is something that I would like all of us to try in a short while. This is the direct impact of something called breathing on respiratory sinus arrhythmia. So what the heck does that mean? Respiratory sinus arrhythmia is actually the thing that gives you heart rate variability. Now, you might have heard of heart rate variability. This is something your Apple Watch, your Garmin, your Fitbit tells you. And if the number is high, i.e. 50, 60, 70, you're in a good place. If the number is low, 20, 10, then you're not in such a good place. Well, what in effect heart rate variability is the ability of your breath to influence your heart rate. And you might be surprised, but one of the ways, you know, because I asked you earlier on, how can you decrease your heart rate? Go on, decrease your heart rate. One of the ways that you can do this immediately is also to breathe properly. And let's talk about this. So a bottom-up approach considers that there is a perfect breath. When I say perfect breath, it's not my perfect breath. It's James Nestor in this wonderful book, which I'll urge all of you to read, which could be life-changing, suggests that 6 breaths per minute, between 5 and 6 breaths per minute, i.e. a cadence of 10 to 12 seconds, which means 5 seconds on the in-breath and 5 seconds on the out-breath, with diaphragmatic breathing can be a very helpful way to get you into the best breath. And what is diaphragmatic breathing? It is not this. This is called a chest breath. When you can see when you take a deep breath in or out, the chest is moving. What a diaphragm breath is, and the way you would feel it is, I guess, if you do this with me now, take your right hand or left hand, put it on your navel now, and go on and breathe in for 6 seconds or 5 seconds. Go on, take a deep breath in. And now take a deep breath out. And what I hope all of you will experience is a belly breath or a diaphragm breath. And what this means is when you breathe in, your diaphragm pushes down, your navel comes out. so often I see in my patients with long COVID the opposite. In fact, in patients with POTS as well, where on the breath in, the belly goes in. And in fact, the whole chest comes up. So it's a breath like this and out like this. And this is the way to breathe that does not use the diaphragm as much. Okay. So this diaphragmatic breathing is quite an important concept, and I guess the best way to do that, Mel, I've seen your thing. Boon, we're at 40 minutes. Let's do 2 minutes. Okay. So shall we do a meditation? And here, not a meditation just yet. I will just show you what I have been recording on my heart math. So heart math is this thing that I have, and it is a device that we'll put a link to where you can get this. It's a Bluetooth PPG sensor that's a pulse plethysmograph. And what I'm going to do is show you my heart math app on the iPad that I'm running now. And if I just launch it, I'm going to do a breathing for 2 minutes. I'm also speaking. I may be a bit sympathetically driven and agitated, but hopefully Mel can talk us through this. We're going to follow the mandala with the breath out and follow it in with the breath in. And I'm going to keep quiet and let Mel talk through what's going on.
So Boon is now, he's got the heart rate sensor on his ear, so it's measuring his heart rate, which you can see just on the top there. And he is looking, or he's thinking in his mind of this breath pacer, and he's breathing at around 6 breaths per minute. And what you can see is, you can see that his heart rate is changing. So the bit at the top is his heart rate, and it's just showing it changing as it goes up, and as it goes down, and as it goes up, and as it goes down. And this is just another diagram. So you can see that it's not static. He's not sitting at a heart rate of 60 or a heart rate of 80. And if you would say, actually, what is his heart rate now? Well, at every second it's different. And what you can see is now it's starting to take a form of a very regular and predictable pattern. So as he breathes in, his heart rate is rising. As he breathes out, his heart rate is falling. As he breathes in, it's rising. As he breathes out, it's falling. And not only that, but you can tell that he's breathing in a very regular and very predictable way. And his heart is therefore listening. And his heart is going up in a very regular, predictable way. And it's coming down in a very regular, predictable way. So what he's actually doing is controlling his heart rate, exactly what his heart rate is doing through his breathing. And we know that that can be supplemented by him sitting now. He had that picture of the lilies, and he's sort of thinking feelings of gratitude. And we can talk a bit about that in a moment. But his feelings and his breathing are directly controlling his heart rate. And that is quite powerful stuff. The score at the bottom is it's a sort of very calculated, very sort of scientific mathematical analysis. And it just shows something called his coherence, which is a ratio of the sympathetic and the parasympathetic activity. And what it's showing now, that he's in a very coherent state, which means that his sympathetic and parasympathetic systems are completely aligned. So if you look at these lovely, regular, predictable heart rate patterns from his breathing, that's the sign that his autonomic nervous system is now functioning in a sort of perfectly aligned way. And if we ask him now to stop breathing and to maybe start talking and to maybe think of something that has annoyed him or irritated him, or maybe to think, Boon, about your next meeting that's coming up in the next 10 minutes, we might see that his heart rate pattern starts to change. He's quite a calm person, so actually we might not. But if it were me, you'd see it become a bit jagged. So you can see already there, the pattern is unpredictable. It's going a bit all over the place. If it was someone more stressed, it would be erratic and irregular. And so this is just a lovely example using this biofeedback device to kind of see how your heart rate can be directly controlled by consciously controlled through you. So how you can use conscious control to control a subconscious. So thank you for that, Boon. And you can see now his heart rate is all over the place and very regular and predictable at all.
Yeah, so I've now lost my heart rate variability, and if I said to you, if I just paused, did a screenshot there and paused it, the heart rate variability pattern that you saw earlier on was like that, and that just means the heart rate is variable. It goes down to 70 beats a minute, and it goes up to 100 beats a minute, and it's variable by that much in a regular pattern. And that means you have a higher heart rate variability. When I started talking, and right now I'm sure this pattern is not so variable, is limited to a very narrow window, and therefore my heart rate variability has reduced. And this coherence score, as Mel said, is something that can come down very rapidly when you start to not focus on the breath anymore. So I'm just going to get rid of that and just come back to here.
It's something that we would probably, that it's useful to do. We don't want anybody to ever get obsessed with the numbers, because that's the worst thing, but it is a useful way of tracking your body responses to your actions. And we're going to move on now. So that's a bottom-up approach. So that's using your body to control your mind. And one of the things that the interesting things to note is that the vagus nerve that we talked about before, it supplies your heart and your lungs and your blood pressure and everything else. It also innervates the part of your brain that controls emotion. So your frontal lobe and your prefrontal cortex and your amygdala, the emotional brain. So actually by doing that breathing, you can control your brain. But now we're going to talk about how we can use the brain to control the body.
Yeah. Yes. And so this is to do with the top-down approach, and we already gave an analogy of how anger and frustration can put you in a sense of frustration and upset or upregulate your fight or flight response. And the opposite emotion of all those things is, in my mind, the easiest emotion to express, and what I teach my patients is a gratitude emotion. And being grateful can be something that we lose focus on very early on in a fight or flight response. And when we're driven with a high degree of adrenaline all the time, it's one of the things that leaves us. And really, if you want to be grateful for something, just start by saying, I'm grateful for the air that I can breathe. I'm grateful that I'm waking up in a bed with a pillow that is fairly comfortable, that I have a house, and that I have a job, or that I have a family, or children, or a spouse, or anything that is so simple that is easy for you to express on a daily basis. Of course, the other very positive emotions that you could focus on would be compassion, love, and a very powerful one is forgiveness, including forgiving yourself for getting into this state where your health has been affected or for catching long COVID, because these emotions are, in fact, one of the key cornerstones to switching your mindset to allowing yourself to recover. So, yeah, I don't know whether we have time for this. If you wanted to, I could do 2 minutes, Mel. What do you think? Should we do it? Do we have time? Joe?
Yeah, if you do it, I think we can. If you both got time, if we go a couple of
Sure.
minutes over 3 o'clock.
Sure.
Yeah.
Okay.
Oh, sorry, Mel.
So I can see that there are 52 members, and I guess for this to work, let's try. Okay, so this will take 2 minutes. I want all of us who are joining this call now and those watching afterwards to simply close your eyes and bring yourself to a calm place mentally, and then start to focus on the breath. Now you can count your breath, or you don't have to count, you just have to breathe. But I would like you to try and slow your breathing down, ideally to a 5-second cadence. But if you can't, then just slow your breath and just breathe in and breathe out. Just breathe in again and breathe out. And let this breath in of gratitude start to relax your head, your scalp, your eyes, and breathe out your nose, your lips, your chin. Breathe in and breathe in gratitude again, and let that gratitude settle on your chest, your arms, your palms, your fingers, your abdomen, your waist, your thighs, your calves, your legs. And just let every one of these bits of you relax completely as you continue to breathe deeply And breathe out. What I want you to think about now is with each in-breath, this feeling of gratitude that in this very exercise that we've just demonstrated, you are achieving a sense of calm as you relax and you are able to gain control and dial down the sympathetic nervous system and dial up your vagus nervous system. You are feeling a sense of calm and relaxation, which is extremely deep-seated. So deep-seated that you're using the combination of a gratitude breath and a slow, deep breath to deeply and thoroughly change the way your autonomic nervous system reacts. Continue for 4 more breaths in and out. And in. And on this breath, bring the gratitude and the breath all the way to an area of your brain just behind your eyes, between your eyes, the autonomic center, and breathe out. You're bringing in your attention and focus to this autonomic center. Breathe in, bringing your concentration back to becoming fully alert and aware. Breathe out. And on the final breath, breathe in. You're going to come straight back to us. Open your eyes and rejoin this webinar and breathe out. So in the comments, if you want to share, tell me how you feel or how that has felt. But when I do this exercise myself every morning and evening, I do feel a really calming sense or calming influence. And it really can set you up for the day in a very good way, set you up for the night as well, sleeping. So Mel, back to you.
So we'll just wrap up, but basically there's a lot on the horizon. This is a new condition. There are loads of studies going on. So first working out what is the spectrum of autonomic dysfunction in COVID and what is long COVID, and then looking at all sorts. But in the middle column, you can see that a lot of the interventions are looking towards exercise, which is great, but also things like singing and mind-body interventions. So this is something that's being widely used. And so just to summarize, this has been a really whistle-stop tour really throughout long COVID and long COVID autonomic dysfunction, and how we propose to treat it. But what we really want to say is that this is something, it's a real example of a condition that's been driven by patients, driven forward by patients, and you know, patients making themselves heard, and are now influencing policy, research calls and grant calls. And so we would just encourage you, if you just click Boon for the final summary slide, just encourage you to kind of show up, carry on, keep educating yourself and keep going. And that, you know, we do strongly believe that actually doing this will be the result, not in just helping the symptoms, but in helping them as you go on throughout life. So thank you very much. And I think we're ready to take a couple of questions, but obviously we'll make sure that they're all answered after the webinar as well.
Okay, thank you very much, Boon and Melanie, for sharing your experiences of long COVID and autonomic dysfunction. It was really interesting, and it's generated a lot of questions actually, and we've had some emailed in as well. So shall we just try and rattle through as many as we can, and then perhaps if you've got time, we could maybe send out an email answering the rest of them.
Sounds good.
The first one is, how long does the fatigue last, and what can you do to deal with it?
So that's a great question. So Don't know. One of the things we do know is one of the reasons for fatigue is this. So thinking back to Boon's kind of physiology explanation, that constant surge of the fight or flight response, so the constant stress response, is exhausting. And so we know that the fatigue can last. So often one of the things to exacerbate it and to make it go on is actually overdoing it. And so we can't emphasize enough really the idea of pacing yourself and managing that fatigue. And one of the key principles is, if you do something, even if it's just doing a bit of exercise, and the next day find that you've got a lot of fatigue and exhaustion, then just pace it right back and put your levels back, and just be as patient with yourself as you need to be, especially in the early stages. And don't what a lot of people do is say, well, how can I, when will I ever get back to my 10K race? And the answer is you will, but just don't rush it now. Boon, do you have anything to add to that?
Yeah, I think expectation setting is very important, extremely important. Pre-COVID, there are many patients I've met who were doing marathons and leading kind of 12, 14-hour shifts or very heavy workloads. And 6 months on, they are way better than they were 3 months on, and yet they feel miserable. And because they are looking at the wrong point of reference. When they look at the reference to the pre-COVID days, they will always set themselves up to a negative emotion. But if you look and you see that every day is getting better in every way, and you actually express the gratitude that your fatigue is there, but it's better than 2 weeks ago, better than 2 months ago, that should send you in a positive mental state rather than keep looking back at what is potentially going to take a long time to get back to. So I think expectation setting has a bit to do with how you tolerate fatigue. Fatigue is very subjective. And I think, look, I'm fatigued. I slept 5 hours last night. And I wouldn't pretend that, this is a normal day, but I know, I know this is something that can recover if I sleep more tonight. Now, I know it's a very, perhaps not quite the same, or not an analogy that is so relevant, but in terms of chronic conditions, particularly also with chronic pain, sometimes setting the expectation is the most important thing that you can do. Because when you get your expectation in the right place, you give yourself the ability to express gratitude. And when you do that, you can cope with the illness process better. Sorry, that doesn't answer the question. The truthful answer is yes, you can recover. It takes time. Manage your expectation of the time it takes.
Thank you. Thank you. Do you think it'll be a couple of years or more before we have better treatments or a cure for POTS? And do you think that the research around long COVID will help?
I think I answered this in the chat as well. My own view is that we already know a lot about POTS. You can only Google PubMed POTS and interventions and attend these POTS symposia or webinars and you can find the latest research. What is severely lacking is education and understanding amongst healthcare professionals and therefore amongst patients who have POTS symptoms who keep being passed from pillar to post and who continue to flounder. All you 49 participants in the group now are already ahead of the game because you know about potsuk.org. The trouble is getting it out there to the rest of the population who may be suffering in silence. So the problem isn't about so much to do with new therapeutic strategies. It's more to do with making the baseline information available to more healthcare professionals and more patients. Sure, I mean, I'm not belittling the role of novel therapies. It's just that there's so much to gain from education, such as just changing your fluid intake, salt intake, pacing, sleeping, compression stockings, that these things are not even done or prescribed. So why would you go to intravenous immunoglobulin or plasmapheresis when you don't drink more than 1 liter and you're drinking coffee and cola all the time? It doesn't make sense to me.
And the other thing is that actually one if you can call it positive thing of long COVID actually is it is It's just bringing these issues to the fore, and it's, you know, it's making doctors and healthcare professionals listen to the you know, the patient voice, and so hopefully that will also bring attention to POTS as well by kind of proxy.
Is there a role for vagal nerve stimulation devices in POTS or in POTS and long COVID?
Oh my God, I should have brought mine today. When I used mine, it caused a bit of a tingle in my tragus. This is the Parastim device. This is your tragus, this thing here. The tragus is said to be the window to the vagus, and it is one of the sensory fibers that affects the vagus nerve. Mel, can I share your experience? When Mel was testing this with Parasim, the device, she had nasal congestion. And it's really interesting. When I used it, sometimes I could feel my stomach churning. So I think there is an autonomic effect, but when I used it with heart math or trying to assess my heart rate variability, I couldn't impact my heart rate. And so I was very disappointed. Mel, do you have any further comments on this tragus nerve stimulator?
Yeah, I mean, it's a brilliant question, because obviously it's something that we've been talking about a huge amount in detail. And so there are no studies to date in either POTS nor long COVID, but there are some studies underway in America in POTS, and we are actually trying to set up a study currently looking in long COVID. And yes, there's definitely rationale in terms of, you know, everything that we're talking about is in trying to stimulate and trying to sort of increase the vagal tone. It's not yet been proven, but it does kind of make sense. It has been shown in other conditions, so it's licensed, kind of FDA licensed in, I think I might be corrected, but in conditions like depression, chronic migraine, and epilepsy. And so it is an area of great interest and great promise. I believe someone told me it's quite expensive, so I think again you just have to balance the risks and benefits, and you know, if it's not been proven, but certainly it's something causing a lot of interest, and watch this space if nothing else.
Can I just exercise some caution there, Leslie? For the tragus stimulator to work, I would have to be a very bad doctor, becoming away from what I would usually prescribe my patients, which is deep breathing and gratitude exercises and fluid and salt, because I think the delta effect, which means the magnitude of effect that one can experience from being positive, from breathing properly, from taking salt water compression, potentially will be more than the effect of a tragus nerve stimulator. So the confounding factor is that there's so many other things to do. And the perfect trial to run, really scientifically, is you take groups of patients who are all doing the best they can, 3 liters of water, 10 grams of salt, compression stockings, breathing, gratitude exercises, and then you put one on a tragus and one on a non-tragus, and then you compare the difference. I think the number of patients you need to run that trial to successfully show an outcome would be very high. So this is my reservation, Leslie. And if you ask me, truthfully, there are many, many other free techniques, like going out in the gardens or going out for a walk in your local park and literally smelling the roses with a deep breath, that could do a lot more for your autonomic vagal stimulation than buying a fancy tragus stimulator, even if it's a cheap one from MedLit.
Thank you. Shall we do one more question, just leading on from that? And that is, have you got any advice for people who get dizzy doing deep diaphragmatic breathing?
Yeah, so I would say sit down or lie down and drink lots of water. So drink at least 500 mils. If you can buy one of those isotonic tabs that is like a Baroka, it's something like ORS, Oscar, Romeo, Sierra, or Noon, N-U-U-N, and drink it and take it in a 500 ml glass of cold water and then lie down, you're less likely to get the dizziness. The other thing you could do is you could try and breathe with a shorter cadence. So instead of a 6-second breath, go 4 seconds. And that could also help with the dizziness. So try those 2 things.
Okay, thank you. So I think we probably better call it a halt here, and we'll do our best to answer as many of the extra questions as we can. That was brilliant. We've had lots of positive comments and feedback already. And Joe, shall I just pass Back to you to round up.
Thank you very much. Yes, thank you so much, both. I thought that was absolutely fascinating, and there's some really lovely comments which we'll share with you afterwards. It's always nice to get that feedback. Just really quickly, I've only just put up on my website today, we do have a breathing webinar with Lorna Nicholson coming up on the 12th of July. So that's just gone up today, which I think you work with Lorna, I believe. So
I sent a lot of patients to Lorna, and lorna.pilates.co.uk. She is wonderful with my patients, and she runs an excellent LongCovid dysautonomia breathing Pilates class. Wonderful.
Absolutely, and I think we're going to do it as a Q&A session, so it's all advertised, and yeah, I think that will be really useful and links into a lot of what you said. We'll send you the questions. Are you happy for us to share the slides with people?
Yeah.
Yeah, so everybody will try and get the slides and the recording out by the end of Monday. The questions might take a little bit longer than that, but bear with us, but we'll definitely email you or share them on Facebook either way. But thank you everyone for attending. Please do take the time to fill in the survey. I promise it is only 2 minutes. And please remember our campaign this July, Take Us Down for POTS. I think there's quite a few medical professionals that have attended today. So if you're on Twitter, get involved and just do what you can to support us, because we're all working towards the same goal. Thank you both so much for giving up your time. Thank you, Leslie.
Thank you so much for inviting us, and to everyone for your amazing questions.
Thanks,
Thank
everyone.
you so much. Thank you,
Bye.
Joy. Thank you, Leslie. Bye.
Bye.